Hello and welcome to Video Journal Club. This is my very first video, and I just want to say that I'm so excited that you're here. The purpose of this particular video is really just for me to introduce the channel, to let you know what you can expect from it moving forward, and to share a little bit with you about what I feel are the joys and power of evidence-based medicine. So with that said, let's go ahead and get into it. So what's all this about? What is Video Journal Club? Well, I'm a medical student in the United States, and Video Journal Club is something that I've been working on for a while now, and it's something that I'm really excited about, and I'd like to share with you why. Over the course of my training thus far, one of the things I've grown to accept is this simple fact, that I am dumb and I am wrong. And I feel as though that statement deserves a little bit more explanation than that. So here's what I really mean when I say that. The reality is, I will forget an unacceptable proportion of the information that I learn in medical school, in postgraduate training, and beyond. Otherwise stated, I am dumb. And going even further than that, even among the things that I think I know, many of those things will later be revealed to be false as we collect more evidence during my years of clinical practice. Otherwise stated, I am wrong, even if I have no way of knowing it. With those sobering things in mind, how then do I become an excellent physician and positively impact the lives of my patients? This is where I believe critical thinking really comes into play. In my opinion, the primary role of a physician is to critically assess the body of available medical evidence and apply that information to individual patients. Appraisal of the medical literature is an essential component to practicing quality evidence-based medicine. In other words, it is an essential component to providing the type of medical care that you can be confident in, the type of care that you can be proud of, and the type of care that is truly deserving of the trust that patients offer to their physicians. So all of those things aside, what is this channel? Where does this fall in? Primarily, my hope is that this will be a place for discussion. My intention for this channel is to share with you my personal appraisals of exciting and influential pieces of medical literature. The goal is not only to highlight things that I find personally really cool, but also to hear other people's opinions and interpretations of the evidence that I present. Really, my ultimate dream for these videos is that someone at some point much smarter than I am will come across my content and tell me exactly why I'm misinterpreting the data that I present. So basically, the bottom line is that this is a channel where I'll walk through pieces of medical literature with you, tell you what I think of them, and hopefully hear back from you. This will ultimately be good practice for me, and hopefully interesting and informative for you. So here's basically a list of the initial topics that I've been working on so far, and that I hope to cover soon. They're not listed in any particular order per se, although I will say that I've really loved working on the presentation related to flumazenil and hepatic encephalopathy, so I really hope that somebody out there watches it and enjoys it as much as I do. So to kick off the actual content of this video, I'd like to begin, as I often will, with an attempt to frame our discussion by talking about something that I think is pretty cool. If you don't think that this part is particularly interesting, please bear with me. I'll get around to the good stuff here pretty soon, I promise. But I really do want to spend a little bit of time discussing this because when I think about clinical trial results, I like to take a step back and keep this very big picture framework in mind. And basically the background of this slide is just that, in the world of business, there's this very simple concept of the decision outcome matrix. And essentially what this highlights is that while decisions can either be good or bad, and outcomes can either be good or bad, it's not necessarily always true that a good decision leads to a good outcome, or that a bad decision leads to a bad outcome. In truth, both in life and in evidence-based medicine, all four of the possible combinations listed here exist. But taking this a step further and specifically applying this model to the interpretation of the medical literature, we find that each of these categories have their own unique advantages and challenges. So let's start by discussing, the scenario in which a truly bad idea results in a trial that has a poor outcome? Well, I would argue that this is actually the most useful of the 4 categories shown here, because it helps to confirm that certain treatments or diagnostic tools are indeed not useful or potentially even harmful. However, the main disadvantage of this category is that historically, there's not been a whole lot of incentive to publish negative results. And so this is a setup for a really large source of bias in the medical literature, which actually has a name. It's called publication bias. And so moving forward in our framework here, we have these 2 categories. And these categories here, in my opinion, highlight the fact that individual studies can easily lead to erroneous conclusions about the efficacy of a treatment or diagnostic tool. To me, this basically stresses the need for robust study design and emphasizes the importance of systematic reviews and meta-analyses in our interpretation of the medical literature. And finally, what I want to discuss at length is this last category, a situation where a truly good idea leads to a trial that produces a good outcome. Well, this last category seems initially to be exactly what we'd hope for. And indeed, it is a lovely thing. It implies that a trial has demonstrated some sort of a benefit. But I would argue that even this type of outcome has its disadvantages. It is well known that profoundly positive results can lead to premature establishment of a standard of care in medicine, to which all subsequent trials must be compared. And I really want to spend the rest of this video with you discussing 2 examples of this phenomenon. Perhaps my favorite example of this is the use of albumin in the treatment of spontaneous bacterial peritonitis. If you've ever been a part of a team taking care of a patient admitted with SBP, you're likely well aware of the most recent recommendations from the American Association for the Study of Liver Diseases, who advocate for the use of IV albumin at doses of 1.5 grams per kilogram within the first 6 hours, and then dosed again on day 3 at 1 gram per kilogram. And you might also hear some people say something like this. And before you read that line and think that you see where this conversation is headed, and you don't want to hear another guy telling you about how perhaps there's some evidence that certain subsets of patients might not benefit from albumin, specifically those with creatinine less than 1 and blah, 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 blah. This is actually not what that's about. But on that subject, I will just say that I find the evidence for this common claim to be shaky at best. It basically comes from a very small study that took about 15 patients who did not meet these criteria, withheld albumin from them, and then showed that none of those 15 individuals died or developed renal insufficiency. I'm simplifying the study design a little bit, but that truly is just about all that they provided in that trial. There wasn't even a control group of supposedly low-risk patients who did receive albumin that we could use to directly compare outcomes. So, after this little tangent, allow me to get back to my main point. I was talking about how the use of albumin in SBP is an example of a good trial with good outcome that nevertheless has put physicians and clinical researchers into an ethically difficult situation. To explain why that is, let's talk about where this main AASLD recommendation comes from. In 1999, Sort and colleagues published a small randomized controlled trial which compared cefotaxime alone with cefotaxime plus albumin with the described dosing regimen that you see above. The results from this study were remarkable. They found profound benefits of albumin therapy. There was an absolute risk reduction of around 20% for both the development of renal failure and mortality. Mortality both in hospital and 3 months out of the hospital. In other words, we're talking about a number needed to treat of just 5 patients for preventing death when using albumin for SBP. These results are incredible. So much so that despite the trial's small size, the albumin dosing regimen used in the trial eventually became standard of care for patients with SBP. But why so much albumin? the paper actually doesn't give a reason for this. And because of that, we're left to assume that it was chosen relatively arbitrarily. And I don't know, what's the issue with that, you might ask? If the regimen works, why does it matter how much albumin is given? I think that the authors of the trial actually answered this question best. In their last paragraph of their discussion, they state, and I quote, "Intravenous albumin is expensive and has limited availability in some settings." This is where this really starts to hit close to home for me. At the time of this recording, as I mentioned earlier, I'm still taking part in my medical training. And I've had the opportunity to work with some wonderful people at lower resource community hospitals in my area in the United States. I've personally seen patients with SBP who did not receive any albumin at all because hospital resources just simply could not accommodate giving that much IV albumin to every patient who is admitted with spontaneous bacterial peritonitis. And even if physicians could negotiate with their hospitals to offer lower doses of albumin to their patients, there's simply not good evidence that lower doses would benefit patients at all. So with that, I've finally circled back around to the main point that I was originally trying to make. The results of this trial were great, and they've shown us that under ideal conditions, we can use IV albumin to save lives of patients with SBP. But the establishment of a standard of care without carefully and systematically assessing the optimal dose of albumin for these patients has created a standard of care which is cost prohibitive for many patients in many hospitals, both here in the United States and globally. So, what can be done to fix this? Unfortunately, this is an issue that's not terribly easy to fix. Once a standard of care is established, it is considered unethical to design a trial in which a group of people are deprived of care which is known to be effective, especially when we're dealing with mortality as an outcome that is improved by standard of care. So that really gets in the way of researchers trying to design good trials to answer whether or not lower doses of albumin might be just as effective. And I'd like to just have a quick side note about something really quickly here and say briefly that there actually was a recent study published in the Arab Journal of Gastroenterology in 2019. In this trial, patients were treated with much lower doses of albumin, nearly 4 times lower than those recommended by the AASLD, with outcomes that were actually very similar to reported data for patients treated with conventional therapy. But this trial had significant caveats. It was a very small observational study of only 49 patients, and there was no control group. So on its own, the data is interesting, but honestly uninterpretable. What I hope is that it at least provides additional support for the desperate need to design a randomized controlled trial directly comparing low-dose albumin regimens with conventional therapy. And perhaps it provides some weak evidence, but encouraging evidence, that withholding a standard dose of albumin from patients in favor of a lower dose of albumin might be a morally acceptable thing to do after all. So shifting gears here, I want to take a minute to just talk about Remdesivir. And whenever I originally made this presentation, I intended to end with the discussion on albumin and SBP. But Remdesivir here in the early May of 2020, when I'm recording this video, has just been dominating news headlines. And I think that it actually illustrates another lovely example of when positive or trial results can put researchers into sticky situations. So I wanted to have a little bit of a discussion about it here, and I intend to only discuss it very briefly myself, as I would like to instead direct you to a beautiful and concise description of the available data on another YouTube channel, Strong Medicine, in a recent video that he made that was entitled, "Will Remdesivir Save the World from COVID?" But with that said, in extreme brief, buzz about 3 studies have made international news in the past few weeks regarding the potential benefit of Remdesivir for the treatment of COVID-19. There was a Gilead trial which essentially showed non-inferiority of a 5-day course relative to a 10-day course of remdesivir, which is interesting, but there was no control arm that did not receive remdesivir. So it's sort of a strange study design in the absence of available robust evidence that patients benefit at all from a 10-day course. So it was a little bit confusing on its own, but it makes maybe a little bit more sense in the context of the other trials that I'll talk about here in a second. But the second trial was a randomized controlled trial sponsored by the Chinese government and published in The Lancet. And this trial directly compared 10 days of IV remdesivir to placebo with a primary outcome of improvement via an established clinical severity scale. And the punchline of this trial is that it showed no significant benefit in either the primary outcome or any of their investigated secondary outcomes. But the study had a major caveat in that it was underpowered, interestingly, due to difficulty recruiting patients in China, where the infection is actually quite well controlled at this point. So the last trial listed here, the ACTT trial, that's the big ticket issue right now. This is an ongoing study. This is the ongoing unpublished study that inspired Dr. Anthony Fauci to suggest that remdesivir should be considered the new standard of care for COVID. And that's the comment that inspired me to include it in this discussion. This is a randomized controlled trial of over 1,000 patients, again comparing 10 days of IV remdesivir with placebo. The primary outcome in this study is time to clinical improvement, which was defined in the trial as having satisfied one of the following. Either the patient is discharged from the hospital with or without the need for home oxygen, or the patient is remaining in the hospital but without need for supplemental oxygen or ongoing medical care. So, preliminary data revealed statistically significant reduction in the time to recovery from 15 days in the control group to 11 days in the remdesivir group. There was also a suggestion of potential mortality benefit from 11% to 8%, though this did not reach statistical significance. So, before the paper has even been peer-reviewed and published, it has faced a ton of enthusiasm as well as a ton of criticism. The reason for the enthusiasm is obvious. It's a robust, randomized controlled trial which appears to have demonstrated significant benefit. But here are some of the criticisms. One of the criticisms that's very interesting is that the primary outcome, as it is written, allows for patients to recover at variable stages within the disease process. So some individuals may be home with no limitations whatsoever. Others may be remaining hospitalized for unclear reasons, but not requiring supplemental oxygen. And while others still may be considered recovered if they are able to return home, but with home oxygen. So basically, as it's written, it seems that the way the authors define time to recovery introduces some subjectivity on the part of providers involved in the trial. And, I think that since this is a multi-centered trial, it would be really interesting to see whether different centers chose to interpret this definition of time to recovery in consistent ways. Another criticism about the primary outcome is that it was changed during the trial. And this is a point that's been discussed at length by so many people at this point that in the interest of time, I'd like to encourage you just to read about it elsewhere. But I will say that I personally believe that the change was small and it's been sufficiently explained by the investigators, and they were very transparent about the change as they were making it. So I just want to say that I'm personally not losing much sleep over that particular point. But one last thing that I will say about the study design of this trial that I find interesting is the inclusion criteria for the study. And so I won't go into a horrible amount of detail, but basically we know that the study is interested in hospitalized patients with confirmed COVID who have lung involvement. But how they define that last piece, that lung involvement piece, is interesting to me. So within their listed inclusion criteria, they say this. They have these 4 criteria, and they're an or statement. So a patient could have any one of these to be enrolled in the trial. And the issue I'm having is that on one extreme, this trial includes patients who are randomized while they were already mechanically ventilated. And on the other extreme, it could include patients who were completely clinically stable at presentation, only with evidence of infiltrates on imaging, which are very common, which are very commonly read on a chest x-ray and have a wide differential. And it also includes patients who are, quote unquote, requiring supplemental oxygen. And this opens up an entirely separate can of worms in my mind because, as it was pointed out in the Journal of Hospital Medicine's popular Things We Do for No Reason series just over a month ago, we routinely use supplemental oxygen inappropriately in the hospital for patients who just do not need it. And so these criteria set up for both critically ill patients requiring mechanical ventilation and patients who potentially aren't very ill at all to be analyzed together. Since I know that this trial must include at least some of each of those different populations of patients, only having the aggregate outcomes is difficult to interpret. There's no way for me to say whether the effect size is being primarily driven by critically ill patients or primarily driven by patients early in their disease course or driven by both equally. We just don't know. And so with that, I want to finally once again cycle back to the main point that I wanted to argue with this. Here we have another trial with a positive outcome. And at the surface, it seems like fantastic news. But there is potential danger in prematurely labeling Remdesivir as a standard of care for the treatment of COVID. In that circumstance, future studies become ethically obligated to replace true placebo arms of their trials with Remdesivir therapy as a point of reference. Having a point of reference that leads to uncertain outcomes makes it very difficult to determine the efficacy of a new study drug. So, final thoughts on all of this as a whole. Appraisal of medical literature is fundamental to our practice. We must recognize that even good treatments have limitations which can be improved upon. And then finally, this last one is a bit of a joke, but in all seriousness, I love putting together this information and making this video, and I hope that you found some of it valuable, and I'm excited to make more. References for everything that I've discussed will be linked in the video description. Please take everything that I've said with a grain of salt and review the evidence for yourself before ever changing your opinion on my account. I've always been kind of awkward with goodbyes, but that's about all that I have to say for now. I want to thank you once again for listening, and I hope that you have a lovely day.